Good afternoon, everyone. My name is Kumanan Rasanathan, and I'm the Executive Director of the Alliance for Health Policy and Systems Research. And thank you, Helen. And thank you so much for joining us here today. We at the Alliance are very honoured to be bringing you the session with Health Systems Global, and also thank you to the governments of Japan and Norway for co-sponsoring this session. It's a great coalition of people who care about health systems, who care about the right to health. And I think at the end of a very tiring week, we're very pleased that you could join us in this beautiful place, and thank you to the Japan Society for hosting us. It's a very serene oasis in a very busy city and in a particularly busy week, and certainly more serene than the struggle for health that was happening outside the door as you walked in. So the Alliance for Health Policy and Systems Research is a WHO-hosted partnership, which I'm honoured to lead, and has existed since, conceived in 1997 and started in 1999, and it supports health policy and systems research in low and middle income countries, aiming to improve health system performance, service delivery, and essentially health outcomes, and help to realise the right to health. This session is very much on how can learning and research fast-track process to achieve global health goals. The three declarations that we've seen this week on pandemic preparedness and response, on universal health coverage, and on tuberculosis. And in fact, it's fair to say we haven't heard a lot about the role of research and learning this week, right? And it's very important to understand the goals and the policies, but policies by themselves don't achieve anything. They need to be implemented. We need to understand, are they working? Are they not working? We need to have the input of not just policymakers, but of program managers, implementers, health workers, communities to drive together. And learning is not just about academic papers. And as a global health community, we often don't learn that well. In 2009, we had a pandemic, H1N1. It didn't turn out as bad as we feared, but it's still, there were hundreds of thousands of lives that were lost. We saw that vaccines were hoarded. We saw that many of the antivirals were also hoarded. And in the intervening period since 2009, we didn't learn anything from that. So then in 2020, when we had COVID, which at the beginning people thought, oh, maybe it won't be so bad, turned out to be much worse than originally anticipated. Over, potentially 24 million excess deaths, and the same things happened in terms of our access to vaccines, in terms of our access to countermeasures. And so that's just one example about that if we don't learn, if we don't have evidence linked to political struggle and social mobilization, lives are lost unnecessarily. So I think we see research and learning as not just an abstract, a nice thing to do, an intellectual thing to do, but as something fundamental we need to do if we really are to implement these declarations, realize these goals, and realize the right to health. So today's session is really about that, and we have a very esteemed panel. And I'd now like to hand over to Professor Anna Meyer from Pace University and Health Systems Global, who is also organising this with us, to also welcome you, and then also to introduce our keynote speaker. So over to you, Anna.
Thanks so much, Kumanan. It is a real pleasure for me to welcome everyone to this event during such a pivotal time for global health. Health Systems Global, for those of you who aren't aware of it, is an international society dedicated to promoting global health policy research for strengthening and developing health systems. We have been a long-standing member of the Alliance, so it's especially gratifying for us to co-organize this event today. I would also like to thank our co-sponsors, Japan and Norway, as well as our speakers and panelists for taking the time to join us today and jumpstart discussions around these topics. We hope to continue these discussions also in our upcoming symposium, which will take place in Nagasaki, Japan in November of 2024. So today we have a great program prepared for you, which we hope will lead to constructive discussions about what is next after these high-level meetings. We will start by a keynote address by the Right Honorable Helen Clark. This will be followed by a panel discussion with representatives from the Ministry of Foreign Affairs from Japan, from South Africa, as well as a representative from Norway. And then we'll have a Q&A session where we hope to have a lively discussion as well. So and then we'll end with some closing remarks. So next, it is my great pleasure to welcome our first keynote speaker. Helen Clark served as the Prime Minister of New Zealand from 1999 to 2008, where she focused on issues like health, sustainability, as well as climate change. Since 2009, she has held various roles in international organizations, including as UNDP Administrator and current Chair of the Board for the Alliance for Health Policy and Systems Research. Welcome to the podium, and thank you again for joining us.
Well, good afternoon, everyone. I think Kubanen referred to being at the end of a long week, and probably this event for many of you is the last heave for the crazy week that UN General Assembly always is. But let me thank also Health Systems Global for the partnership with the Alliance for Health Policy and Systems Research in co-organising today, and of course the governments of Japan and Norway for co-sponsorship. I became chair of the Alliance board at the beginning of this year, but am not new to health issues. I was a young health minister back in the late 1980s, kept a close interest in health issues as Prime Minister, then at UNDP, and since then to association with the global health ecosystem and with a range of hats on over the years. So let's start by saying that this week has been the summit which marked more or less the halfway point towards the Sustainable Development Goals, which are so important for global health. But we have to be frank about where we stand. We came into this week with dire warnings from all over, dire and accurate warnings about how off track the Sustainable Development Goals are. Only 15% of the targets are on track to be reached, and nearly progress has either stalled or actually reversed on around a third of them. And the truth is, if we limp like this to 2030, the very concept of goal setting in the multilateral system will be called into question, because people will say, what's the point? And we have to make sure that there is a point. And I believe what we're here to discuss today, which is really about how evidence should inform building decent systems and getting decent policies in place, is part of the way that we can get some more traction. We're all aware of what's been holding back progress or sending progress into reverse. At the Partnership for Maternal, Newborn and Child Health, which I also chair, we talk about the 3 C's, the horrible 3 C's of climate change, conflict and COVID. Put them all together at one time, you have agony. And we've seen, particularly in the COVID period, where childhood immunisation rates went to a 30-year low. We've seen the WHO report earlier this year that tells us that global reduction of maternal mortality has absolutely stalled and is going up in a number of countries. So I suppose the question of this week will be, have the high-level meetings, the SDGs summit, the UHC summit, TB today, pandemic was Wednesday, have they refocused attention on these issues? Will there be the financial commitments to turn ideas into action? Will the SDG stimulus proposal of the Secretary General get traction? It calls for another $500 billion a year being leveraged from the multilateral banking system. But I would note that a lot of countries are so debt stressed now that borrowing ain't the most attractive proposition. That we need really a good injection of old-fashioned grant money as well. So I think we come together today, the research community saying, well, what can be the role for research and learning to drive progress in the global health area? And note that there have been very few references to the importance of research in these meetings, right? We read a little in the declarations about monitoring and digital innovation, technology transfer, but research hasn't been a feature of it. And I think the mission of the Alliance is to try and get research at the centre of the action so it can make a real difference. Because, we're not achieving the health goals or any other goals really, except for the 15%, on current approaches. And as the old cliche says, doing the same thing over and over and expecting different results is the definition of insanity. And none of us want to contribute to that. I think that health policy and systems research can obviously be a bridge of taking us from the ambition of the goals to actual implementation. It can help us document what's worked and what hasn't, can help us learn, can help us improve implementation. And we can, celebrate the successes that they are and share them and encourage people to adapt from what has worked. I'm given the example, for example, of Thailand's journey towards universal health coverage. Through a committed approach to health policy and systems research, it identified what were the key barriers and what would be the enablers for UHC, and that guided the development of their policies, like the so-called 30 baht scheme in the early 2000s, which enabled low-income households to access services for a nominal fee, and that fee is now gone. Terrific. The policy didn't emerge in a vacuum. It hasn't been static. It was informed by politics, of course, because, as Rob Yates of Chatham House will always remind us, universal health coverage is popular with people, right? People want it. But the approach was also informed by a lot of data and analytics about how the health system was being utilised, what was cost effective, and what were the social determinants of health. So I think also in a fragmenting world, health policy and systems research can build collaboration. The pandemic has underscored the importance of multi-sectoral partnerships and approaches for effective responses, from combining health data with supply chain logistics to integrating public health measures with economic policies. We just had to collaborate across sectors to have effective responses to COVID. And this systems-wide approach is so central to what health policy and systems research can provide. Health policy and systems research can also help us keep our focus on equity in the fight against TB, for example, being discussed in another forum today. We can't ignore the role of the other conditions like HIV, malnutrition, diabetes. Health policy and systems research can help us understand the complexity of how these challenges intersect and help us create policies that address them in an integrated way, and we can be more effective. So I suppose the main point of what I want to say is research and learning in this area is not a kind of nice to have optional extra. It's actually extremely important in helping us to navigate the complexities of systems and policies, and to help us find new solutions and help us, where necessary, reallocate and redirect resources for greater effectiveness. Research is a strategic investment. That's the message we need to get across to ministers of finance, who are often a little tight-fisted about these things, as we know. But it is important, and it will help us do better in the future, and ideally help put global goals like those in the SDGs back on track. So thank you, Kumanen, thank you everyone, and look forward to the discussion from the panel. Thank you.
thank you, Helen. And you've done so much in health over your career, but it's interesting, as you gave that speech, I mean, there's all these different meetings happening this year, and you're one of these people who's at the center of all of them. And it's lucky that you don't actually sleep so that you have enough time to do all of this. But I think, beyond that, to say that, you know, certainly in your work, whether as in a government, whether at UNEP, you are someone who has said, yes, you need evidence, and you've merged it with the politics to drive change. And I think it's not at all to suggest that you don't need political movements and political choices and will and commitment, but without learning and evidence to then work out what the prescription is. And I think the examples you summarise are really where that has happened. And I think even when you look at something like universal health coverage, where we're bemoaning this week from the report that things have gone backwards for financial protection on a global level. But there are still, as Bruce Elwood from WHO reminded us last night, there are countries that have gone forward. You know, I had the privilege to be in Tamil Nadu last week in Chennai. And if you look at what has happened there over the last 20 years, both in terms of improvements in services, the breadth of services, still really building on previous models of community health workers and community participation, and then seeing incredible increases in life expectancy, reductions in mortality, driven by evidence and also political choices. And at that point again, which we're hammering you over the head, is that health policy and systems research is one of those levers to unlock that promise. So following Helen, thank you so much for setting the scene. It's now my privilege to introduce this very esteemed panel that we have. So I'll introduce them one by one. So firstly, we have Dr. Satoshi Ezue. Dr. Ezue is the Director of Global Health Strategy at the Ministry of Foreign Affairs in Japan, in Tokyo. We also have Ambassador Jonana Rottingen, who is the Global Health Ambassador for Norway. I think you're the first Global Health Ambassador for Norway. Also a former chair of the board of the Alliance for Health Policy and Systems Research, so someone who's doing the sort of global health diplomacy, but very much understands the role of health policy and systems research. We have Professor Norbert Njeka. Thank you so much for joining us, even while the TV event is going on today. You have the very challenging task of being the Director of TB Control and Management in South Africa, a wonderful country where the Alliance and Health Systems Global, we have a very strong health policy and systems research community in South Africa. So thank you so much for joining us. And then we also have, you've already met Professor Anna Amaya, who's a professor at Pace University, but also a board member of our close friends at Health Systems Global. So if I could invite the panelists to join the stage. Working? Can you? Yes. Okay. And I was remiss, I'd also like to acknowledge the people who are online, and thank you so much for joining us in addition to the people here in New York. It's one of the things, I think, one of the sort of silver linings out of COVID, one of the few that we've learnt much better, that we can engage people more broadly, not just people who are in the place. And we'll also have a chance for the people online to ask questions as well. So thanks so much for joining us. So the first question I'd like to ask actually to Dr. Ezue. You know, Japan has been at the forefront of the movement for universal health coverage and health system strengthening for so long. There's been really important, for example, G7 summits that have led to sort of really impactful moments. And you continue, we heard the Honourable Minister Takemi last night, and he's now the Minister, but he's been a real driver of that as well. So I'd be interested to hear your perspective of what has driven Japan's commitment, and how have you seen the importance of evidence in driving that commitment, and also reflecting on the recent G7, how Japan we talked about a learning hub there, and then looking forward to next year in Nagasaki in November 2024, which will be the next edition of the Global Symposium on Health Systems Research. Maybe just reflecting on why Japan has gone in this direction and what your aspirations are for the recent commitment and the summit and the symposium next year.
Thank you so much, Kumaran, for the great question. And first of all, thank you very much for inviting me and to invite us to co-host this event. And thank you so much, Health Systems Global, and also the Alliance for Health Policy and Systems Research, as well as other panelists and Prime Minister Clark for making this happen. As someone already said, it is a long week, and I must confess that I am a bit exhausted. But I'm also glad that I can, conclude my long week with this session, which is dear to my heart and to my country. And so I will talk briefly about three things. One is why we are so interested in promoting UHC. And the second one is about just a summary of the G7 deliberations, which we are still following up on. And also the third thing is about Nagasaki Global Symposium next year, November in Nagasaki. And so, first of all, so on the why UHC, why so keen on UHC? So there are, of course, many reasons, but one of them is that from our national context. So we created this universal health insurance system in 1961. And that was not when Japan was, rich and we were not fully recovered from the World War II. But there was a really political momentum and a political choice to really cover everyone with a decent basic healthcare. And that led to our economic development, socio-economic development, as well as creating one of the longest life expectancy healthy country. Of course, there are many challenges, but largely speaking, we are one of the healthiest population in the world. So that shows that universal health coverage is not a luxury. It's a necessity when you want to really develop and then maintain and create a healthy society. So that's the basic experience of Japan. And we are convinced at the highest level that this should be not only the Japan's experience, but expanded to basically the whole world. So that's the basic narrative and the justification for us to really promote this concept of UHC. And so, for example, the late former Prime Minister Abe Shinzo, he was one of the champions of this agenda. And actually 4 years ago, when we had the first high-level meeting on UHC, I was posted here in the New York Mission, right next to this building. And so we wanted to, first of all, convene this high-level meeting on UHC. We thought it's time to do this, besides other preceding health high-level meetings on health, like HIV, NCDs, TB, and MR. So we thought it's time at that time, just right before the COVID, we should do a high-level meeting on UHC because it's we see that as a fundamental to all the health and also all the SDGs. So the Prime Minister really owned this agenda, and he came to the meeting and closed. In the closing, he addressed the high-level meeting to really realize this UHC by 2030. But as we all know, the COVID-19 hit several months from that meeting, and we all know the story afterwards. But that moving on to the G7 health outcomes from the Nagasaki Health Ministers meeting as well as Hiroshima Summit, So I was one of the coordinator for setting the agenda for those G7 discussions, and the main thinking was that we need to, of course, address and follow through the COVID-19 response, but we also want to refocus our attention on the fundamental agenda such as UHC and health system strengthening. And because we were busy tackling COVID-19 for the past 3 to 4 years, and so other health challenges like the maternal child health, healthy aging, NCDs, AMR, and other important infectious diseases like HIV, AIDS, TB, malaria, and neglected tropical diseases were a bit sidelined. And so we thought it would be time for us to refocus our attention to other important health challenges, but not in a piecemeal way, but under the overall umbrella of universal health coverage. And so that was the main concept. So we, I won't go into the details about the actual outcomes, but that was the main concept, and we really tried to refocus our attention to the universal health coverage. And so we came up with 3 main agendas. One is the global health architecture discussions, which is ongoing and which is very important, of course. But the second one is to really refocus our attention to the universal health coverage, which is, the other side of the coin. And the third one is about health innovation, which includes medical countermeasures. And so that's the gist of the G7 deliberations, and we are still a presidency until the end of the year. So we are following up on different outcomes from that, but we also wanted to feed that discussions into other forums, wider forums like G20 or the high-level meetings here in UNGA and the WHO and other forums. So that's what we have been doing, but the main concept is to really refocus our attention to the universal health coverage, so that we can make sure that we can really achieve UHC by 2030. And the third part, so on the Nagasaki Global Symposium, so I have asked the Secretariat to circulate this blue postcard. You may be able to actually use this as a postcard if you want. So we will be convening this, the 8th Global Symposium on Health Systems Research. And again, we just wanted to show our commitment and respect to the cause of this symposium. I myself attended the first Global Symposium in Montreux, more than 10 years ago, and we have been following and supporting this important symposium, so we thought we could contribute by hosting this. And some of the key highlights, so maybe 3 highlights. So, well, before that, please mark your calendar already. It seems to be a long way, but it's only 1 year. So it will be in November 18th to 22nd of 2024 in Nagasaki. And so 3 points. So the city of Nagasaki is actually I'm from a city near Nagasaki, which is Fukuoka, but it's a beautiful city, and lots of great food and hospitality. It has been an open port when Japan was closed for more than 200 years. It was the only port that other foreigners can come. So it has a really open-minded and culturally really diverse and very, very interesting history. And so the place itself is very, very good. And of course, it's a city of peace because of the atomic bomb experience. So I think that city is the best position to host this symposium. The second part is that, so this is the first time that our development agency, JICA, is co-hosting this. This is the first time that the developing agency of any country is co-hosting this symposium. So that means that we are really interested in action-oriented outcomes from this research symposium, especially in the low and middle income countries. So that is the intention. And the third point is that we will be taking up planetary health for the first time in this symposium. So we are expecting not all the discussions, we're not saying that all the discussions should be planetary health oriented, but we will take up this important area. So we are expecting major discussions around climate change and health as well in this context. Let me stop here, and again, thank you for having me. Thank you.
Thanks so much, Dr. Ezra. And it is an exciting opportunity. As you say, it is the first time a development agency is co-hosted. So we have high expectations, and we know the food will be excellent. But more than that, we hope this sort of triggers a thinking on the field of health policy and systems research and how it can be more impactful, which is the theme of today's session. And I think really to inform that sort of political leadership that Japan and other countries are doing to sort of refocus on after COVID and get us back on track, or maybe not even getting us back on track, because we were really on a sufficient trajectory even before we weren't, but there's much more that can be done, and so that's very exciting. So maybe I can move now to you, Ambassador John-Anna Röntgen. So you're a global health ambassador, so you go to lots of meetings like this, right? And Norway is a major contributor to global health development. You've recently commissioned the future of global health initiatives with other partners to think about how the architecture can perform better with all the crises we face. But you're also a very esteemed researcher in your own right. You led the Norwegian Research Council. So I think you've got a very interesting position to say why you think health policy and systems research can contribute to the sort of policy and political things that is your current job. So over to you, John-Anna.
Well, thanks, Kumaran, and thanks for inviting me, and in many ways inviting me back to a community I at least used to know, but some years since I've engaged really with the Alliance. It's also good to be back intellectually to reflect more on the systemic and the broader policy-related issues than we actually do in a health ambassador job or in busy meetings like this. I've taken off my tie, so in a way it's an indication that I'm relaxed and back home in some way. We are all heading back home, and I think it's good to have this event at the end of the week, because I'm not happy really with where we ended this week, and I can get back to that. And research and learning is an important part of what we need to do before we improve on how we worked collectively. But maybe first some reflections, because when we say research and innovation, I think many are thinking about, okay, we need new tools, we need new tests, new therapeutics, new technologies, new digital technologies. But we need to understand that those are just means, and they cannot deliver without really integrating them fully and making sure they are used to their most value. In one of my earlier roles, I was very much interested in working on cost effectiveness, clinical trials, understanding how we can really make sure that we did identify the most effective and cost-effective interventions in healthcare. We then talked a lot about the no-do gap, in a way that we had a very strong evidence base, and indeed, if we could really implement those cost-effective interventions, health outcomes would have been much better. So it was not really about the need to have new tools and interventions, but it was about implementation. And that calls then for implementation research and making sure that we also understand how to deliver those. But it's really not only about implementation, because, as you know, and in particular in a week like this, and it's such a busy environment, we understand that health is about policy, it's about politics, it's about interests, it's about systems. That's on the local and national level, it's also on the regional and global level. And we need to also understand and intellectually address those issues from a research point of view. And that's why health policy and systems research, or health services research, as we also can call it, is really key. Norway has been one of the founders of the alliance, together with other countries. I think the founders have been still trustful partners, but there are still too few sort of trustful partners of the alliance. And maybe that is a reflection that we haven't really reached out sufficiently well from a community of those interested in trying to improve health outcomes, not only from developing new tools and technology, but actually the broader system discussions. And you talked about now post or not post-COVID really, but at least after the health emergency part of the COVID pandemic, we have now had 3 high-level meetings. They are different. A disease focus, one of our biggest infectious disease killers, still very large gaps to address. Then sort of I shouldn't call it the new kid on the block, but really what is now taking up a lot of policymakers' capacities, health security, pandemic preparedness and response. And then, as Toshi also mentioned, UHC as the overarching umbrella. And I think really having such an umbrella is good. And maybe we should have tried to have more of a holistic thinking also on how we address these 3 different but important health topics in this year. And because we are living in constrained times, post-pandemic, inflation, conflict that are taking away resources, both domestically and also on the aid side. Countries are more indebted. We need to be even better at achieving essential health services and delivering them in a UHC approach than we have been before. That's about being effective and efficient when it comes to domestic resources, and that's the core investments needed. But it really also is about being effective in how we support from external funding, so health aid or what you can call at least the collective world's responsibility to help those countries that have the highest needs. And I think we are not really delivering sufficiently well, and that's why we have embarked from the Norwegian end together with Kenya and many other countries, both on the implementing partner country end. Japan is involved on the donor end together with other donors. How can the bilateral and the multilateral health financing system support countries' plans, priorities more coherently and more aligned? And that's, of course, it's a political discussion, it's a policy discussion, but it's also what I think we see now when we have commissioned a research report conducted by 5 universities. We also see that there are gaps. We need to better understand how can we translate those ambitions into real action. And that calls for health policy and systems research, and maybe as an integrated part of thinking about delivering on that agenda moving forwards. And maybe as a final comment, as I said, I'm really not pleased how we are delivering now 3 declarations this year. And it's not because I'm surprised, because that's the way we have tended to deliver UN or WHO-related declarations and resolutions. And the way we work as a community, as a universal system of almost 200 countries, that was developed in the 1950s. It's 75 years old, and we still work in the same way. And at least this year, I think we've demonstrated that this does not deliver. It doesn't deliver commitment, it doesn't deliver then actions, and it doesn't deliver health improvement and outcomes. And that also calls for research. And that's also a type of health policy and systems research. How can we really work very differently? When you have, at least from the starting point, 200 committed countries to make the world a better place, how do we end up spending endless hours in meetings negotiating text that ends up with texts that are even worse than the texts we had 4 or 5 years ago? You can say that's not a research question, but I think it is. It is an innovation issue, it's a research issue, and it's about understanding what is driving this kind of way of doing diplomacy. And this was not said in a diplomatic way. Sorry.
Norwegian diplomats are perhaps a bit more frank and don't wear a tie. Is that right?
Maybe.
No, it is an interesting point, and I think one of the interesting aspects of the work of health policy and research is that it works at different levels and across different sectors. And so we have Albert here, who does participatory action research with communities and social movements. You've talked about the research that Carl Blanchet and others at University of Geneva did looking at the global health system. And so it really does act across different levels. It is true that probably some of the life experiences and processes that have changed the least in, say, the last 70 years are sometimes the process of accessing healthcare and the way we do international negotiations, right? So there's something to reflect on there. If we can move to you next, Professor Amaya. I mean, you're a researcher at Pace University, but you are, I know, very proud to be on the board of Health Systems Global. And I wondered what some of your reflections have been around the high-level meetings. And I mean, Jonana has given us quite a pessimistic prognosis there, but also then the role of Health Systems Global and of researchers and how they can contribute to perhaps addressing some of these flaws. And ensuring that the research doesn't just end up as a paper, but really creates at least an impact that improves people's health.
Yeah, thank you so much, Kumanan, for that question. And I'll start just with general reflections of the meetings, and then speak a little bit about what I have observed from the discussions, especially on research and learning, also looking at the political declarations themselves. And then I'll speak a little bit about the role of HSG and what we are looking forward to next year in Nagasaki. So first of all, we know there's been great variation in these 3 political declarations, especially in terms of not just content, but also process. We have always known these were going to be non-binding agreements. But in my view, it's still important that these issues are being discussed at this level. We need to really continue to uphold these discussions if we're going to expect any action to happen, especially around these 3 very interrelated topics, which I think one of perhaps the weaknesses of this week is that we haven't done well enough in integrating how can we bring them together and address them together. What are those linkages? So yes, it's important to build on this momentum, on the energy, but also try to prepare for the shocks and make sure that we're not using any other health emergencies, which obviously COVID-19 has significant effects on the political declaration in UHC, for example, in 2019, but making sure now that we know that these things are possible, that they can happen, and that it's still fresh in our minds, how do we make sure that we're creating these resilient systems and responses to make sure we are staying on track despite these changes? So in terms of research, I was very pleased to see that most of the political declarations were actually calling for evidence-informed policies. Particularly the UHC political declaration mentions evidence-based policies quite a few times, which is really good. But we do see that both the UHC and the PPR political declarations do mention in their operative paragraphs some calls for innovative mechanisms and financing mechanisms for health research and development. But this is primarily focused on the production of pharmaceuticals, drugs, and health products. So it's really an onus on the private sector as a creator of these new innovations, and not as much the role of the wider scientific community and the implementers, the policymakers, who are also involved in research and who are crucial to have in the table. So I think it's really on all of us to really bring to front the importance of not only this type of research, but also social science disciplines, right? And social science approaches, not only just to behavioral change, but also to address health inequities, as Helen mentioned earlier. So I think for us as a research community, it's really our responsibility to speak a little bit louder and also a bit clearer about the contributions of our work, not just the sort of writing papers, right, as Kumanen mentioned, but how do we make sure this actually becomes implementable? And we also need to think about how do we overcome the barriers for the use and uptake of evidence-based policies. We need stronger commitment for embedding these expert consultation processes in these discussions at the high level meetings, but also before that. And also ensuring the public dissemination of evidence, really creating this trust with the public. Researchers aren't always the best in communicating with the public in very clear ways, and unfortunately, we saw that also in COVID-19. But also building relationships with policymakers and working towards greater co-production of research with implementers and policymakers, and not staying in our silos. And unfortunately, academia is quite frequently one of the groups that stay in their silos. So in addition to all of this, I also, as I joined some of the discussions and the panels, I heard quite a bit of calls for involving researchers in discussions, but very little about how and what amount of research, what amount of funding is needed to support this research. We know that we crucially need much more funding for locally produced research and greater investment in building the local research capacity, especially in low and middle income countries. There's also some calls about making these goals happen. And obviously many governments have spoken about the importance of these goals, but we've also heard very little about concrete actions and how to make this happen in a realistic manner. It's actually interesting because we've all been following the health discussions that it might have been easy to ignore that there's actually a science summit also happening this week. And so that science summit has found some really interesting outcomes in terms of how much is being invested in low and middle income countries for science and for research. Obviously, especially low income countries have only been found to spend less than 0.5% of their gross domestic product on science, compared with 3% in high-income countries, which isn't a great number either. But what we do see is that the research that's being produced in low-income countries actually is much more aligned to the SDGs and to fulfilling those goals compared to high-income countries. So we're seeing that these countries are really interested in finding solutions, interested in taking these goals, the Sustainable Development Goals, seriously, but obviously they need support to do this. So there has been some discussions about budget priorities and different debt relief mechanisms that I think are really important to continue to have. So just to finalize, because I know I'm running out of time, as has been mentioned today, Health Systems Global is really committed to being a convening space for researchers, policymakers, activists, donors, governments to have these discussions around health policy and systems research. We have this great opportunity in Nagasaki to really bring these discussions in a perfect venue, such as Japan, which is really pushing forward these topics. I think what we have learned from this week's discussions is the important role of multilateralism in supporting health systems around the world. And so I hope we continue this next year. Thank you.
Thanks so much, Professor Amaya. So, Professor Njeka, I mean, tuberculosis is on the one hand, you know, the disease, the classic disease of poverty. It's a disease that it studied by the McEwen hypothesis, which showed how the social determinants, essentially, before we even knew about the bacillus, you could reduce the incidence of tuberculosis. At the same time, it's also the disease that, in spite of the millions it kills, we haven't had a new vaccine for 100 years, right? We were reading today about the challenges in South Africa you're having around patents for medicines, right? So you have a tough job, and we wondered whether you could reflect a bit on South Africa is a powerhouse for health policy and systems research. It's a country, it's a leader on social struggle, the leader on the HIV movement. But your reflections on how has research and learning influenced or guided your efforts in South Africa around TB, and how then are you engaging and looking at TB as a systems problem? So over to you, Professor Njeka.
Yeah, thank you so much for inviting me, and thank you for the important question. In fact, TB is a big problem. In South Africa, with only 60 million people, we do get 300,000 TB patients every year. That's really a lot. I mean, this is estimated. We've been trying to find those 300,000. It's not working. Last year, we only managed to diagnose 224,000 patients, which is quite a big gap, but the gap is closing, which is very, very encouraging. The other issue has been that mortality has not been decreasing enough despite efforts, but also 56% of the population undergo catastrophic costs due to TB-related issues. And those are just ingredients for problems, for further hardship. But the TB epidemic in South Africa is driven by HIV. We have almost half of our TB patients were people living with HIV, which is quite difficult to deal with. And more so that we know with recent challenges like COVID, pandemic, and all that, people have been losing jobs in large numbers. So it really makes it difficult to control tuberculosis. But what we've really been trying to do is to be evidence-based in terms of decision-making. We realize that government cannot do everything alone. We have world-class academic research. So we work with them, we work with the NGOs, and that really helps a lot to find people with TB and treat them. But also we decided to engage civil society so that nobody is left behind. So working with all these people has been really very, very important in terms of finding TB, treating, and all that. Now, some of the key things that we've learned in the process, which have really helped to get results, have been things like identifying gaps, identifying the required investment that we need to put into things. It is common that you get HIV investment studies in countries around the world, but it's rare you get TB investment. So we decided to start doing that so that we really understand what is cost effective, what is the most cost effective intervention in order to focus on those. Although the challenge with that is that some of the things we don't do may be good to do, but you will not find evidence. For example, vaccine. you won't find evidence of using an effective vaccine. You need modeling. Then people start arguing this modeling and all that. But TB investment, to learn what is critical in terms of investment is very, very important. But rapid adoption of new tools is something that we tried, and that is possible because of involvement, because of engagement with our stakeholders, particularly the academia. Because when you get new tools, new diagnostics, new treatment, usually people are not comfortable. We recently started to treat all our patients for 6 months, MDR TB patients. And people are not very comfortable with such things. They're really used to their 2 years or 18 months. When you say now 2 years will do 6 months is possible, you have to educate people, and sometimes your healthcare workers are the ones that have more challenges than the patients. So rapid adoption is very, very important. But you can only do that if you have parallel research and implementation. A lot of people are of the opinion that we should first do all the research and then finish them, then you start implementation. I don't think we have time. We don't have that kind of time, because we're saying 2030 we need to end TB. And if you look at where we are now, we still need sputum to test for TB. But we also understand that we have to be doing a large-scale testing. We need something simple like maybe saliva or tongue swab, and we're not yet there. The treatments, yes, we're talking 6 months now. We're planning to start. We've started. Other people haven't started. But even 6 months is not good enough. It's too long. We actually need 2 months treatment for tuberculosis. Now imagine if we stop where we are and we're going to do a lot of research and find maybe in 5 years' time that the 2 months works, or it's going to be really a big problem. So parallel process of research and implementation is really critical. And there are also rapid decentralization. A lot of good ideas in TB remain projects for many years because they have to be well done. They have to be done at universities, hospitals in the big cities, and you find that many years down the line, you have one center of excellence. Almost everybody is cured in that facility, but if you go in that same country, you go around the villages, you go outside the capital city, you find that diagnosis is not happening, treatment doesn't happen, and all that. But more important, really, it has been a strong collaboration. I can't really stop talking about that, because collaboration with academia, with NGO, civil society is critical, because then you're able to, have the same message. Because usually we don't understand things the same way. When you say evidence-based, it's not the same for everybody, So if you sit around the table, you discuss, it's very, very important to have. But what's critical, my final remark, is really around the general health system. You need a strong health system. We do, get a lot of results because, for example, we don't have TB lab on its own. We have a general lab where the TB component is strengthened and all that. So domestic funding is really contributed. We appreciate the external funding, but there is a great deal of local domestic funding and overall health system strengthening that really support the TB the work of TB. That's why we're able to see some of the achievement that we have. Thank you so much.
Thanks so much, Professor Njapa. And I think your comments about not waiting to finish the research, in embedding it in implementation, the role of communities, those differences between can't just be about a single center of research excellence. I mean, what is this doing for the system? I mean, those are very, very well taken. Former Prime Minister Helen Clark, if you'd like to join us again on the stage. We do have to ensure that former Prime Minister Clark gets her taxi at 3:00. And so we don't have so much time, and I really don't want to be the person who ensures that she's late. So, but I think we've had a very sort of a really range of perspectives about the role of research and learning in different settings, from the global to the community. We don't have a lot of time, but we do have probably time for one or two brief questions. So I would like to open the floor if anybody wants to ask a question. So I see Abe and Shamila. So Abe, would you like to go first?
So thanks for this very stimulating and diverse panel discussion. But what I felt was a bit missing was the role of people as protagonists and research around the lessons of COVID, of what happened at the community level in countries across the world, which people did themselves for their own country. And the way in which they interacted with health systems in new ways, in collective ways. They set up isolation and quarantine centers, they collaborated with frontline health workers in many ways. So many things happened which are unprecedented. And also the way in which public systems interacted with the private healthcare sector to regulate them, or to channelize the resources, or to harness the resources during COVID, which is unprecedented. At least in India it happened on a large scale. And these are new phenomena which need to be researched, which need to be understood if we are not to lose the lessons of COVID. We have lost a lot of other things in COVID. Let us not lose the lessons of COVID. It's very valuable. And they have probably, co-production of health and healthcare, interventionist regulation, social accountability of private healthcare providers, expanding the range of public actors. And the whole idea of public is not just the government system, but it's a larger range of public actors. And advancing public risk in health systems as a whole as an essential component for moving towards UNC. So I'd like your thoughts, any of you, how can these lessons, these experiences be researched? If you require a different kind of research approach, it will probably not be a randomized controlled trial, but we need to look at many, many valuable lessons which are much which are missing in the dominant discourse, in my opinion.
And thank you, Abe. And I know Ambassador Rottington also needs to leave a little bit early. So for the people online who maybe couldn't hear that, it was really about, are we missing the role of people and the innovations because of COVID, because of these emergency settings on not just the co-production of knowledge, but driving changes in practice and the intersections between people and health systems, people in the public sector, the private sector. Shamila, do you want to ask a brief comment?
Thank you for some really important comments. I think you said it, sir, that everyone knows that health systems are important to health of people. And everyone, though, very few people, very few donors actually want to fund health systems research. And I want to thank Japan for their unwavering commitment from a long time to UHC. And taking a page on from what Prime Minister Clark had said, he said that research is the center of action. And so that for me, that is the essence of, as a health systems researcher, is political. So I was wondering if the panelists can, in terms of trying to think of how we do things differently. And I really appreciated Ambassador John our European diplomacy. I think this is what's needed. Is first, evidence. We have a deficit of trust, and I think Andy spoke about it. A deficit of trust around evidence, a deficit of trust around public health, a deficit of trust in science. So what does that mean for research? And the second is, in a way, health systems research, the political part, was about really naming somebody else into the room. And I think one of the things, on reflection, and I'm complicit of it, is that there's an assumption that there's a scarcity of resources. I know the economics are not good, But because of the sense that we have the scarcity of resources, and if you think of how much money is spent on military spending versus on health, the differences are stark. So what we've done is rely on the private sector. And 25 years ago, we kept talking about public-private partnership and wanted to make it work, and it was a slippery slope. And I am part of that, as supporting it and the research on it. But somehow we're in this state now where we saw from the pandemic with the vaccine apartheid what happened. And your commission from Mr. Clark, I think, was phenomenal. Some of the issues. The other issue is what we're seeing now in terms of the private equity. Here in the US, private equity is buying up emergency rooms, cardiologist practices. Isn't that what health systems research should call it? And the third is I'm going to talk about consulting firms. And a case in point, in New York City, there's a hospital called Montefiore, and those people who don't know, it was one of the war zones. It was Montefiore Hospital, Elmhurst, in the height of the pandemic. Recently, a consulting firm did an assessment because they are losing money. And guess what got cut? The primary health care. And Montefiore is in the Bronx, where the issues with NCTs is a really big problem. So, in a way, I guess what I'm saying is this week hasn't resulted in anything. And I'm just wondering, for me, health system has been it's a political process. And these issues, which I know some can name incredibly well, but how is the Alliance going to deal with these issues? I know you have a working group.
So it's hard to summarize that question and comment for the people online, but I think the issues around the deficit of trust, how are we responding in terms of research, issues around the private sector, the role of specific interests within the health sector, how are we going to deal, a lot of things have changed, and including how is the Alliance going to deal with it. And then, Brian, did you want to ask one?
I'll be very, very quick. So, because Professor Mai, you talked at the Science Summit that happened just before this, and given we're at one of the biggest diplomatic convenings, I was wondering if you could, and given we have two diplomats here, and former diplomats as well, could you speak to the role of science diplomacy in kind of aligning a lot of these interests around, what the priorities are, what we should be researching, and then how we leverage that? Thanks.
Great. So that was a question about the role of science diplomacy. So unfortunately, I think we're going to have to go to the panel, especially because Ambassador Rohning is going to leave, and then Ambassador Clark. So what I would like to ask the panel is just to take, less than a minute each to engage which of the issues that have been raised, or to say your final message. How do we ensure that research and learning and policy and system research does what we say actually can fast track where we want to go on health? And I'll start with you, Ambassador Rohning, just because I know you may be leaving very soon.
Yeah. Sorry about that, but I also have a taxi from a hotel nearby soon. I maybe just take on the issue on trust and the role of science, because this, of course, been expanded as a problem during the pandemic, but it's not new, and we've seen it before. And I was head of vaccination programs, infection control in Norway, so continuously the only way to engage with that is really engaging in open discussion and debates, not trying to sideline or sidetrack dissenting voices, but really trying to demonstrate that the research and the evidence base. And I think that is also, as you, Sharmila, you in a way talked about the political nature of health systems and priorities that are made. And that is also an important role of health systems research. Absolutely. Is to play that independent role, challenging authorities, challenging those in power and in power positions. And that's why we need academic institutions, freedom of speech, freedom of academic freedoms, and the role to be able to criticize. Finally, on science diplomacy, I think, of course, that is something I have tried to engage a bit in after I took on this job 3 years ago. We are in a difficult, when you're talking about trust between sort of citizens and their authorities maybe, but we also are in a situation of sort of horizontal distrust across nations, across communities. The health inequities were a strong driver. but we also have definitely other geopolitical tensions. And I think collaboration in research and discussions across research, among research communities across nations is an important part of trust building. I must say, and I also said that if you saw in particular the sort of genetic sequencing, the sort of basic research around COVID-19, that became a global open community of effective sharing of research and insights, much more sort of open and sharing than health authorities were or private sector were. So how can we really build on that crowd way of learning together and do that as a health system? But sorry, I need to leave you. Yeah.
Great.
Thank you.
Thanks so much, Ambassador Ronald. So I'll go.
Just picking up on John Arna's last point, I mean, it does point to the importance of keeping those relationships among researchers across the geopolitical divides. Often when things get tough, those relationships wither. But it's so important to try and keep that discourse and exchange between Chinese and Western researchers, Russian researchers, and the West. I mean, Russia has tremendous history of scientific research, but to what extent are these relationships affected by what's happening? So, in a way, research also needs to be tracked to diplomacy, doesn't it? To just keep that dialogue and exchange going. There are two other points I was going to pick up on. First, the role of communities and knowing about what community feedback is about, what works. I recall going to West Africa during the Ebola outbreak, and some of the most effective things you saw were when communities mobilized to make a difference. And actually, the countries didn't get on top of the disease until the communities were mobilized and knew and understood and engaged. I remember young people being brought on board, and one place I went to, I think Monrovia, where they were going door to door to try to identify the cases, and they were just so engaged in the response, and I was very, very impressed by that. I know in my own country with COVID, there was no way a one-fits-all approach was ever going to work. The Māori indigenous community had to have their way of dealing with it. The Pacific community did, the Asian communities. You needed to let 1,000 flowers bloom in what was going to reach people to effectively mobilise against it. And one last point, Kuman, I'm co-chairing another Lancet commission, which is looking at how you try and understand what the factors are that make for effective resilience to health threats. And we've all noticed, how wrong the Global Health Security Index was. I often make the point that in measuring the readiness to deal with the pandemic, they've put the US and the UK first and second. New Zealand was 37th, had by far and away the lowest death rate in the Western world. But actually, rich country status was not a predictor of having a good response. Actually, the countries that had experience with contagious infectious diseases were much better prepared. Their people were more onto it. And we're also trying to look in our commission at these issues of how populism destroyed the possibility for leadership, how societies which are not cohesive can't pull together at times like this, how trust in your authorities having expertise in serving the public interest is rather important. So there's a lot of factors that go into effective responses. Therapeutics, vaccines, diagnostics, masks and oxygen are important, but if no one trusts anyone out there, it's very hard to make those things work, isn't it? And if you have leadership that's actively denying what an effective response might be, that's not going to work either. So it really just shows the interconnections, I think, of what we try to do on the ground in health with the way the broader society and political systems operating.
Thanks, Prime Minister Clark. Professor Njeka, do you want to have a last word?
Yeah, so what I can say is that prior to the past high-level meeting UN high-level meeting on TB, there was a meeting in Moscow around the multi-sector accountability framework. 5 years down the line, we've had reports from countries, but very little around what happened with regard to the accountability framework. I think in countries, we need to continue to reinforce issues around accountability. Scientists are best in doing that. When you work in government, it may be difficult to keep track, but you need to measure all those things and continue to engage politicians because they are responsible. Without political commitment, we may not achieve all these things. But also people in government must be involved in research, can do operational research to support the main body of research. Thank you.
Thanks so much. Dr. Zoe.
Sure. So technically our time is up already. So just one point. Not that because Young Aune already left, but I just wanted to share some positive view around these political declarations that we just agreed. So I think the positive aspect is that we were able to finally agree and adopt the declaration in this difficult time. Itself is a very positive thing because we were afraid that we could not make it because of some geopolitical issues. But the fact that we were able to adopt the declaration gives us hope. And of course it is not perfect, and there are many things that we wanted to get in, but we do have some positive aspect, and then by definition this is a political declaration, so it's not necessarily technical. But so this is to push politically important issues such as UHC, TB, and PPR, but that is not sufficient. And so we in order to turn that political declarations and will into action, we need research, science, so that's why this community is very important in terms of health system research. So yeah, I just want to end by a positive note. So that's my last point. Thank you.
No, it's very important. Thank you, Dr. Zoe. And as we are over to Professor Meyer, if you could, as my co-host, a very, very brief word, and I'll give a very, very brief closing.
Yes, well, thank you. Very great questions. I think underlying among all of these questions are, again, these political decisions and the importance of engaging with governments and engaging with policymakers at this level to really push these agendas forward. Of course, the role of science diplomacy, very close to my heart, and a great entry point also for discussions for health. A lot of times I think we don't consider the scientific community enough, and our colleagues and our collaborators that are possible in other sectors, because we, again, need to stop thinking about health, just health, but also other social systems. So thank you again.
Great. So thank you to our panelists, thank you to our audience, thank you to the Japan Society, thank you to people online. I think to close, you say, is that we have this precious field of health policy and systems research, and we think it can make a difference in primary healthcare and universal health coverage, in digital health, in non-communicable diseases, in emergency response and preparedness, in climate, this existential issue. But the community of researchers need to work with communities of people, with communities of policymakers to show that it's true. So that is the challenge for us at the Alliance. That's the challenge for Health Systems Global. We are very fortunate to have governments like in Norway, in Japan, in South Africa. At the Alliance, we're very lucky to have Prime Minister Helen Clark to lead us and push us for impact, because as a politician, you always push the evidence that it mattered, that the reports made a difference. So that's a challenge for all of us. Please keep in touch, push us, critique us, and make sure that we can do research that addresses all of these complex interlinked challenges and makes a difference, so that these declarations are positive, they are an opportunity, it is achievement in this current climate that they got 3 declarations. And I think we have a great community to take that forward. So thanks so much, everyone. Have a safe trip home.